My name is Mark McLaren. I was treated for an acoustic neuroma over 16 years ago. Even back in 2001 and certainly today, after my diagnosis, I went to the internet. And the internet can be a place of great information. It can be also a place of great disinformation. This particular tumor is extremely slow growing. While you have to make good decisions of how you're going to address it, it is not something you need to jump up tomorrow and make a decision. You can take your time to really understand your options. You can take your time to talk to as many physicians and get their perspectives, get their experience levels, get the different ways it can be treated.
So an acoustic neuroma is a benign tumor of the 8th cranial nerve. The 8th cranial nerve has a auditory component and a vestibular component. The auditory component is important for hearing, the vestibular component is important for balance, and the acoustic neuromas are generally benign tumors that come off the vestibular nerve. The nerve has axons, which are actually where the electrical signals go through, but just like in a wire where you need something to help conduct that electrical activity, these nerves have protection around them called the Schwann cells. So acoustic neuromas are actually off of the Schwann cells of the vestibular component. So the tumors are also called vestibular schwannomas. We often pick these up what's called incidentally, meaning they have some symptom that's not related to the acoustic neuroma or vestibular schwannoma, and we find it on imaging. Patients who actually have symptoms from their acoustic neuroma, most commonly asymmetric hearing loss, will warrant either an MRI or an audiogram or both. And then some patients present with dizziness, vertigo, and depending on the size of the tumor, if the tumor is large enough, it can cause facial numbness, very occasionally facial weakness, and even compression of the brain leading to weakness or numbness of the body. So there's a population of patients who have something called neurofibromatosis type 2, who have a genetic syndrome that's passed down from generation to generation and leads to acoustic neuromas, often in both sides. And then there are environmental factors for patients who don't have genetic syndrome. Those environmental factors are not well studied. So certainly radiation in the past can lead to benign brain tumors. So for example, in the 60s, we used to treat acne patients with full face radiation, and some of those patients end up with benign brain tumors. Then the other environmental factors are widely debated. You know, when I see a patient with a brain tumor, I always try to think, what if I were in their shoes? And if I had a brain tumor or some medical diagnosis, I would want everything done immediately, like yesterday. However, often, you know, it can take some time to make sure that we get all our I's dotted and all our T's crossed to make sure that we get the right diagnosis and get all the information possible before deciding what the next treatments are. When we first see a patient in consult, we try to make it as easy for the patient as possible and have them see all the physicians who would be important for their care. Usually this entails at least a neurosurgeon, a neurootologist who's an ENT surgeon who specifically takes care of skull-based tumors, and then a radiation oncologist. We want to get all the information possible, and we want to make sure we review all your imaging and information carefully. Initially, we want to do a thorough neurologic physical exam to ensure that we're not missing anything, and to make sure that it helps guide what our treatments are. A thorough neurologic exam to ensure that we can guide our treatments moving forward. We also want to do a thorough, what's called a history. We want to know what the symptoms are, how long they've been going on, any past medical history, any family history, anything that makes the symptoms worse or better. All this information, including the neurologic exam and the imaging and the audiogram, will help us determine what the best next steps are. Okay, so an audiogram is basically a test done by an audiologist. You go into a sound protected room and they play a bunch of sounds at different amplitudes and frequencies, and they basically do a very careful test of your hearing. It gives us a good baseline of what your hearing ability is, and if there's an asymmetric loss that would be consistent with your acoustic neuroma. And that information helps guide us to decide what the best treatments are. As part of the diagnostic pathway, imaging is really what helps us secure the diagnosis of an acoustic neuroma. An MRI with and without contrast is really the best technique that we have. Although if some people can't get MRIs, so in that case sometimes a CT with contrast can also be helpful.
Any kind of imaging test that a patient is going to undergo as part of their care, any kind of image-guided procedure that is being performed, that's a radiologist who is going to interpret that particular imaging study or perform that particular procedure. An MRI scan where we can get much more information about the type of tumor, about its location, its relationship to important structures that the surgeon will need to know when they do their surgery. And we can also get some what we call functional information about the tumor and the normal tissue around the tumor. The CAT scan, it's done often in the acute setting when the patient just had the first few symptoms. A CAT scan basically uses X-rays to image the brain or other regions.
So once we have the full history and physical images and audiogram, the hard part comes in, which is the discussion with the patients, the risk benefits and alternatives to the different treatment options. The 3 different treatment options include watchful waiting, stereotactic radiosurgery, or surgical resection. So for patients who have either incidental tumors or small tumors that aren't growing, we can do what's called watchful waiting. Basically, there are risks and benefits to all of our treatments. And if we think that there's not a huge benefit to taking out the tumor or treating the tumor, then we would just continue to follow the patient with MRIs to make sure that it's not growing. If it does grow in the future, then we could treat it with one of the other 2 options at that point. Surgical resection is as it sounds. It requires general anesthesia, an open surgery with a neuro-otologist and a neurosurgeon, with the goal of taking out as much of the tumor as safely possible. Often we leave a little bit along the 7th nerve, which is immediately next to the tumor, because the 7th nerve controls the function of the face, and we'd like to spare that.
The surgeon will often give us a piece of tissue during the operation, and the neuropathologist basically drops what they're doing, goes to the operating room, and we have a very rapid process of assessing that under the microscope and can provide a preliminary diagnosis under that setting. But on a more permanent basis, the surgeon will give us the remainder of the specimen. We process that to give us slides to look at under the microscope, and that process may take as little as 1 or 2 days, or if we need to do special stains or other studies, a few more days.
Stereotactic radiosurgery is high-dose radiation just to the area of the tumor, sparing the brain and allowing very little radiation to the rest of the non-tumorous structures. It's usually done between 1 and 3 days, and that's an outpatient treatment option that doesn't require general anesthesia or an incision. So after you have treatment, you'll be continued to be followed by the neuro-otologist, the neurosurgeon, and the radiation oncologist. Sometimes the patient will require other sorts of therapy, including physical therapy, occupational therapy, or vestibular therapy if they're having a lot of balance issues. We have a multidiscipline approach, and each surgeon and physician also has a team of supportive nurse practitioners and medical assistants who also help take care of the patient. So there are risks and benefits to every treatment option. Those risks and benefits are very individual depending on the patient, their tumor, and what treatment they have. The physicians who will take care of you will discuss the specifics of each of those risk benefits, and weighing those risk benefits to decide what treatment you have is paramount to our consults. Again, our goal is to always try to treat the patient as if we were the patient ourselves and what we'd want done with us.
16 years have passed, and I get asked a lot of times, are you happy with your choice? Are you happy with the treatment you made? And my answer is absolutely. The tumor is not only not grown, which is the goal of stereotactic radiosurgery, it has shrunk. It's been really interesting to see all the advancements that are happening both in diagnostics as well as treatment. And the awareness of physicians to consider an acoustic neuroma has improved greatly.